Okay, so this was where we stopped last week. We discussed gout, we discussed colchicine, allopurinol, naproxen. We discussed all these medications for the management of gouts. So this is the next question. I'm just going to put up the question and we're just going to go over the question just the same way we've always done. Anemias are a collection of blood disorders which may develop for reasons including poor dietary intake of vitamins and minerals. Which of the following would be a suitable treatment for megaloblastic anemia with a low vitamin B12 and a low folate level? Which of the following would be a suitable treatment for megaloblastic anemia in patients with a low vitamin B12 level? So well done everyone that's attempted. I've got a couple of C's. Well done, well done, well done. Okay, so my first question is megaloblastic anemia. What kind of anemia is it? Is it microcytic or macrocytic? Is it microcytic or macrocytic? What kind of anemia is megaloblastic anemia? Does anyone know? So the first, what we're looking at today, first of all, is anemias. Okay, so we've got microcytic anemia. My question is megaloblastic anemia microcytic or macrocytic? So Presh said macrocytic, which is correct. Victor also said macrocytic. Okay, so what is the major parameter we're going to look out for in terms of blood tests? What's the major parameter we're going to look out for in terms of blood test results? What value are we going to look out for in patients with macrocytic anemia? Does anyone know what are we going to look out for? So folate levels, okay, vitamin B12 levels, okay. So macrocytic anemia can either be due to low folate levels or it can be due to low vitamin B12 levels. So Minnie said MCV, that's what I was looking for. Okay, so MCV, which is the mean corpuscle volume, the mean corpuscle volume. So would that be elevated or would that be lower? Are we going to have a high MCV level or a low MCV level in macrocytic anemia? Yes, so macrocytic anemia, the patient would have a high MCV level, okay? And remember I said macrocytic anemia could either be due to folate deficiency or vitamin B12 deficiency. So for this question, the question says that the patient has normal folate levels. Okay, the patient has normal folate levels and low vitamin B12 levels. So treatment is with hydroxycobalamin. Okay, so what will be the dose of hydroxycobalamin? Does anyone know what the dose of hydroxycobalamin is in the management of megaloblastic anemia? So 1 milligram every 3 months. Okay, thank you for me. 1 milligram every 3 months. That's the maintenance dose. Okay, that's the maintenance dose. 1 milligram every 2 to 3 months for the management of megaloblastic anemia. Okay. So, like I said, anemia could either be macrocytic or microcytic. So, with microcytic anemia, what parameter are we going to look out for? What kind of deficiency? What are the causes of microcytic anemia? Yes, so microcytic anemia could be caused by iron deficiency. Okay, and it is characterized by low MCV level, while macrocytic anemia could be caused by either folate or vitamin B12 deficiency. So don't forget that. And we said the maintenance dose of hydroxycobalamin injection is 1 milligram every 2 to 3 months. That's worth remembering. What are the general symptoms of anemia? What are the common symptoms to expect in patients with anemia? What are the common symptoms to expect in patients with anemia? Okay, so if you said fatigue, okay, what else? Shortness of breath. Thank you, Victor. So fatigue, shortness of breath, breathlessness. That's correct. Thank you, Fumi. Pallor, headache, dizziness. Those are symptoms of anemia. Okay, so this question, the patient has low vitamin B12 levels, okay? If the patient has low folate levels, then we'll need to give folic acid. What will be the dose of folic acid? What will be the dose of folic acid for folate deficiency? Follow me properly. You're free to check your BNF. So what's the monitoring requirement annually? Yeah, so BNF says annual monitoring is required before 5 years of treatment. Okay, especially if they have additional risk factors. Okay, so annual monitoring may be started before 5 years of treatment if additional risk factors for retinotoxicity exist. Okay, so that's worth remembering as well. So that's one of what you need to remember with hydroxychloroquine. What are the common indications for hydroxychloroquine? Common indications for hydroxychloroquine. Used for malaria prophylaxis. Okay, what else? Rheumatoid arthritis. Yes, it's a DMARD, SLE. It's a DMARD, so yes, it can be used for rheumatoid arthritis. It's used for malaria prophylaxis and SLE. Okay, so which of these medications is used in patients who are on isoniazid? Which of the medications on my screen is used for? Okay, option E, pyridoxine. Yes. What vitamin is pyridoxine? Vitamin B what? Vitamin B6, yes. So pyridoxine is vitamin B6. It's used for the prevention of isoniazid induced peripheral neuropathy. Isoniazid induced peripheral neuropathy. Okay, so for this question, I think we've covered everything we need to cover. Remember, microcytic, micro is due to iron deficiency. Micro is due to iron deficiency, while macrocytic can be either due to vitamin B12 or folic acid deficiency. And for macrocytic, we're going to have elevated MCV, while for microcytic anemia, we're going to have lowered MCV volume. All right, so next question. D brings his 5-year-old son to the pharmacy. The child has been complaining of ear pain for the last 24 hours, alongside a fever and restlessness. Which of the following is the most appropriate treatment for him? Okay, so I've got a couple of people have chosen A, a couple of people have chosen D. Okay, so Minnie, is there a reason why?
So I'm just going with the paracetamol, and then only I will go for the antibiotic and other lines.
Okay, okay, thank you. For me, what about you? Is there a reason you chose paracetamol? Or does anyone want to tell me why?
Well, I chose paracetamol because the history is just 24 hours. There is nothing to show if there is any otorrhea, nothing to show if it was a middle or outer ear. So I think the first line should still be paracetamol until proven otherwise.
Okay, thank you. Thank you. So for this patient, this is a symptom of otitis media. Okay, the patient is having ear pain, fever, and restlessness. Those are typical symptoms of otitis media. And like Fumi has said, generally with otitis media, the first line is painkillers, okay, paracetamol or ibuprofen to help with the pain and the fever. Okay, antibiotics can be recommended, but in only severe cases. Okay, for example, like she said, if it's bilateral otitis media in children over the age of less than 2, okay, if the patient is systemically unwell, if the fever, patient has severe fever of greater than 38 degrees Celsius. But generally, first line for otitis media is paracetamol or ibuprofen because it's self-limiting. Does anyone know how long do we expect to see relief with otitis media? How long does it take? How many days does it take? It's actually 3 days, okay? It's about 3 days. It takes about 72 hours. It takes about 72 hours. So within 72 hours, we should expect to see symptom improvement. But this patient has only had the symptom for just 24 hours. So these are just typical symptoms of irregular otitis media presentation. Okay, so we would start with paracetamol or ibuprofen, and if there is no relief or if it's severe, okay, or if there is otorrhea, but generally what you should know is over the counter because you might get patients coming to the pharmacy. Though otitis media is now part of the pharmacy first conditions that can be treated, but even with pharmacy first, we're not just going to prescribe amoxicillin first line. We're still going to prescribe some Otigo eardrops for the pain. So that's what you need to remember for otitis media. And if we need to treat with antibiotic, what are the treatment options? If the patient is severely unwell and the patient qualifies for antibiotic, what will be the treatment option? Amoxicillin. Thank you. But remember that you need to look out for penicillin allergy. What if the patient has got allergies to penicillin? It's going to be a macrolide. Remember that most cases, patients with penicillin allergy, the next alternative for them is a macrolide. So clarithromycin, like Mini and everyone has stated, clarithromycin is a suitable option. Or if the patient is pregnant, erythromycin is advised. So that's what you need to remember about otitis media. If you go to the BNF, it lists some conditions, or nice CKS lists some conditions when patients would definitely require antibiotic treatment. But generally, it can be treated initially with painkillers. Okay, so let's talk about otitis externa now. Which of these medications would be used for otitis externa? A, B, C, D, or E? Which of these medications would be used for otitis externa? A, B, C, D, or E? B. Yes, well done, well done, well done. Ear cam spray. Ear cam spray can be sold over the counter. Is that true or false? Yes, it can be sold over the counter. Okay. What's the age licensing for ear cam spray? What's the age licensing for ear cam spray over the counter? Does anyone know? It's actually age 12, okay? Age 12. So ear cam spray can be sold from age 12 over the counter. Yes, meaning 12 is correct. All right, so with otitis externa, what are the symptoms to expect? What are the symptoms to expect with otitis externa? Ear pain, okay? So otitis externa affects the outer ear. It affects the outer ear. So you might expect to get ear pain. The patients might also have some form of discharge as well. Okay, ear pain, some form of discharge, itching as well, itching and redness of the outer ear. Yes, itching and redness of the outer ear. It's an outer ear condition. So with otitis media, the child might remember that this condition, especially otitis media, is more common in children. So with otitis media, the child would have pain inside the ear. Okay, and ear tugging. That's one of the symptoms. Pulling of the ear. That's one of the symptoms of otitis media. However, with otitis externa, it affects the outer part of the ear, so itching and redness of the ear. So, what group of patients would more likely have otitis externa? What kind of patients? Swimmers, yes. Okay, it's also called swimmer's ear, so it's more common in swimmers. It can also be patients that have certain skin conditions like eczema. Okay, so we've talked about differences between otitis media and otitis externa. So over the counter, what's a red flag for referral? Can you think of any red flag for referral for otitis externa? Because obviously it can be treated with ear cam spray, but what's the red flag that will require referral? Loss of hearing. Okay, what else? Mastocytitis. So also, if the patient presents with a foul smelling discharge, yes, that's what I was going to say. Thank you, Ifoma. Foul smelling discharge, that's a very common one. It shows that the infection is severe. So foul smelling discharge, you need to refer the patient because obviously you can't treat otitis externa um, with antibiotics over the counter. So generally, what antibiotics can be used for otitis externa in severe cases? So if an oral antibiotic is needed, which one will be used? Yes. Thank you, Victor. Thank you, Presh. Flucloxacillin. Okay. Flucloxacillin. Remember, flucloxacillin is generally used for most skin infections. Okay, especially infections caused by what microorganism? Flucloxacillin is used for infections caused by what microorganism? Staph aureus. Yes, Staphylococcus aureus. Okay, Staphylococcus aureus. So give me examples of where you see flucloxacillin used as the first line. Can you list any that you remember? Flucloxacillin can be used as first line for treatment of what conditions? So Ricard impetigo, pressure cellulitis, that's correct. Casey said cellulitis, skin conditions, okay, skin and soft tissue, insect bites, flucoi. So a good way to remember it is flucoi, COI, C for cellulitis, O for otitis externa, I for impetigo, and there's a second I as well for, has anyone mentioned insect bite? Yes, insect bite. Okay, so for most skin and soft, remember otitis externa affects the skin, it affects the outside of the ear, so that's a way to remember it. So olive oil eardrops, what over the counter condition is olive oil eardrops used for? Earwax remover. And what questions do you need to ask before selling olive oil eardrops over the counter? What do you need to check for? What kind of allergy? Yeah, check that the patient hasn't got nut allergies. Okay, well done, Thomas, well done, Rukayat. Yes, check that the patient doesn't have nut allergies. If you're not sure, just give sodium bicarbonate eardrops. That's a suitable option for earwax. All right, so I'll move to the next question now. Some of the olive oil eardrops have, some of their excipients have nuts in them, so we do not, some of their excipients have ingredients that could affect people with nut allergies. That's the reason why we don't recommend it. All right, so I've got the next question. So which of the following is least appropriate? Least appropriate. Least appropriate. Any other option? So the correct option is option E. Okay. What's the optimal target blood glucose when driving? Yeah, so remember 5 before you drive. Okay, 5 before you drive. That's the way to remember it. 5 before you drive. So the target blood glucose when driving is 5 millimoles per liter. So generally, we advise patients to check their blood glucose level within how many frequency while driving? What's the frequency that we advise patients to check their blood glucose while driving? Every 2 hours, yes. Every 2 hours. So you shouldn't pass the time. Option A is correct because it says a maximum of 2 hours should pass. A maximum of 2 hours should pass between the pre-driving glucose test and the first glucose check while driving. Okay, so 2 hours, it shouldn't pass more than 2 hours. We want them to check it every 2 hours. Okay. Um the target blood glucose level is 5, not 4.5, so 5 millimoles per liter. So what group of patients should check their blood glucose level while driving? Is it every single diabetic patient or not? What's the advice from DVLA regards drivers and patients who have got diabetic? So those with type 1 diabetes and those on insulin, okay? So patients on medications that can cause hypoglycemia. Okay, so patients on medications that can cause hypoglycemia, patients on insulin, patients on sulfonylureas as well. Okay, generally DVLA advises that they should check their blood sugar level while driving. And why do they? Okay, that's because of the risk of hypoglycemia. So what symptoms do we expect in patients with hypoglycemia? What are the symptoms of hypoglycemia? Dizziness, confusion, tremor, okay? Slurred speech, drowsiness, shakiness. The patient starts shaking. Those are the symptoms of hypoglycemia. So I've got a list of symptoms on my screen, and you just tell me if it's hypo or hyper. Okay, that's the next exercise we're doing now. So confusion or difficulty concentrating, is that likely to be hypoglycemia or hyperglycemia? Confusion or difficulty concentrating. Yeah, in severe cases of hypoglycemia, the patients might get confused. Okay, severe cases of hypoglycemia, the patients might get confused. Difficulty concentrating, yes, so that's a symptom of hypoglycemia. It could also be a symptom of hyperglycemia, but it's more likely with hypoglycemia. Hunger, is hunger hypo or hyperglycemia? Hunger is hypoglycemia, okay? And the way to remember it is that with hunger, when the patient is hypoglycemia, the hypoglycemic patient has low blood glucose, so the patient tends to feel hungry. Okay, we're still going to look at polyphagia later, but hunger generally, acute hunger is hypoglycemia. What about polyuria? Polyuria is hyperglycemia. Remember the three P's of diabetes. What are the three P's of diabetes? Polyuria, polydipsia, and polyphagia. Okay, those are the three P's of diabetes. So polyuria is hyperglycemia, not hypo. Shakiness or tremor. Shakiness or tremor is hypoglycemia, okay? Shakiness, patient starts shaking, tremor. Okay, that's a symptom of hypoglycemia. Abdominal pain. In what group of patients would abdominal pain occur? Abdominal pain is a classic symptom of what? DKA, yes, well done. Diabetic ketoacidosis. Is diabetic ketoacidosis caused by low blood glucose or high blood glucose? It's caused by high blood glucose. Yes, so remember that. So diabetic ketoacidosis is caused by high blood glucose. One of the key symptoms is abdominal pain. Okay, abdominal pain is caused by high blood glucose. And in terms of management of diabetic ketoacidosis, what do we give initially? What are the treatment options? What do we give initially? We give, so Minnie said IV soluble insulin. Okay, what else? What else do we need to give as a matter of priority aside insulin? What else do we need to give as a matter of priority? Fluids, yeah, we need to replace fluids because remember that patients that have got diabetic ketoacidosis, they are dehydrated. So they are losing loads of fluids, especially with the increased urination. So fluids and insulin, soluble insulin, are the priority treatment options for diabetic ketoacidosis. So sweating, okay, the answer is revealed already. Sweating is hypoglycemia. So most times they might give you a question in the exams where the patient comes into the pharmacy and you notice that the patient has an insulin tag or the patient is diabetic based on the patient's medical history. And the patient is shaking, the patient is visibly shaking, the patient is sweating. Okay, would that be hypo or hyper? That would be hypoglycemia. Okay, and what does NICE, based on NICE guidelines, how much sugar in grams do you need to give the patients? How much sugar do you need to give the patients in grams? How much sugar for patients with hypoglycemia do you need to give the patients in grams? 15 to 20, yes, well done. Okay, but obviously 15 to 20 grams of sugar, but that comes in different form. It could be in via it could be via teaspoonfuls of sugar. Okay, it could be via fruit juice, right? It could be how many meals of fruit juice would make up for that 15 to 20 grams of glucose? 150 to 200 ml, yes, of fruit juice, okay? 3 to 4 gram of sugar, 15 to 20 gram of 3 to 4 gram of glucose. That's what we need to give. Um, so palpitations, is that hypo or hyperglycemia? Is palpitations hypo or hyperglycemia? Palpitations is hypoglycemia. Okay, palpitations is hypoglycemia. Polydipsia, we've mentioned polydipsia already. Polydipsia is hyper. Remember the three P's. Polyphagia as well, excessive hunger. What's polyphagia? Hyperglycemia, yes. So remember we said hunger on its own, acute hunger could be due to hypoglycemia, but excessive hunger, chronic excessive hunger could be due to uncontrolled diabetes. Because when insulin is deficient, the cells are not able to absorb glucose for energy, and that could cause hunger as well. Fruity, smelly breath. This is the key diagnostic feature for what condition? Diabetic ketoacidosis. So yeah, this is what you should look out for in the exam. The patient has ketone breath or fruity smelling breath, then think about diabetic ketoacidosis. And finally, blood vision. Blood vision. Blood vision could actually be both hypo and hyperglycemia. Okay, blood vision could be hypo and hyperglycemia. So with hyperglycemia, it's due to the glucose crossing, covering the lens of the eye and causing blood vision. So blood vision could be hypo or hyperglycemia. But remember that in the exam, they're not going to give you only one symptom. So they're going to give you a group of symptoms. So it's going to be easy if you have a good understanding. It's going to be easy to know, oh, if this is a case of hypo or hyperglycemia. Nausea and vomiting. Which of these conditions could cause nausea and vomiting? Is it hypo, hyper, or DKA? Is it hypo, hyper, or DKA? Nausea and vomiting, DKA. Remember, we talked about abdominal pain with diabetic ketoacidosis. So, nausea and vomiting is another symptom of diabetic ketoacidosis. All right, so this is the next question. Okay, I've got a couple of option B. Does everyone agree that during sick days, patients would continue their insulin? So option A says stop all insulin until she feels better. That's wrong. Okay. Remember that during sick days, patients should continue their use of insulin. That's the learning point from this question. Okay, and also they need to check the frequency of their blood glucose very frequently. Okay, so check blood glucose every 2 to 4 hours. Check blood glucose every 2 to 4 hours. Yeah, I've got some true or false questions. So patients with type 1 diabetes should always continue insulin even if they are not eating. Is that true or false? Yeah, they should always continue their insulin. Okay, they should never advise patients to stop insulin. However, they might need to adjust the dose. That's why we recommend that their blood sugar should be checked very frequently. Okay, what's the frequency? How frequently should patients check their blood sugar during sick days? Yes, every 2 to 4 hours. Okay, every 2 to 4 hours. So number two says blood glucose should be monitored only once a day during illness. Is that true or false? Blood glucose should be monitored only once a day during illness. That's false. We said it's every 2 to 4 hours. Okay. Next one. Okay, this is what we said already. Blood glucose should be checked every 2 to 4 hours during illness. This is true. Okay, that's correct. Patients with type 2 diabetes taking metformin should stop the medication temporarily if they are vomiting or dehydrated. Is that true or false for metformin? What other medications need to be stopped if patients are vomiting or dehydrated aside metformin? Okay, so Prash said SGLT2 inhibitors. Okay, what else? What else? ACEI. So remember your sad man drugs. So sad man drugs should be stopped temporarily during sick days if they are vomiting or dehydrated. So medications like SGLT2 inhibitors, your empagliflozins, your ACEIs, diuretics as well, metformin, NSAIDs, ARBs, they should be stopped during sick days. Insulin doses should never be adjusted during illnesses. Is that true or false? It's false. Okay, patients should. That's the whole essence of checking their blood sugar very frequently so that the dose could be adjusted if necessary. So this is false. Option number six is sick day rules apply only to insulin treatments, to insulin treated patients, not to those on diet or oral agents. Is that true or false? It's false. Remember, we just listed STADMAN drugs. Okay, so sick day rules also applies to SGLT2 inhibitors, to metformin, and to patients on other oral medications. Okay, so next question. So this patient is showing signs of digoxin toxicity. Which of the following is most likely to contribute to digoxin toxicity? Okay, so well done, well done, well done, well done, Presh, well done, Victor, well done, Kendi, well done, Joy, well done, everyone. Yeah, so furosemide, and that's because it can cause what electrolyte disturbance? Hypokalemia, yes. Hypokalemia can predispose the patients to digoxin toxicity. So what are the symptoms you would expect in patients with digoxin toxicity? What are the symptoms? Yellow vision, okay. Joy said vomiting, nausea and vomiting, that's correct. Dizziness, okay. Fatigue, nausea, vomiting. What about appetite? Does it cause increased appetite or not? Does it cause increased appetite? So does it affect appetite? Okay, so it could cause loss of appetite. So those are the symptoms of digoxin toxicity. But remember the yellow vision, yellow halo vision. That's a key symptom of digoxin toxicity. That's what you should look out for in the exams, yellow halo vision. But there are other symptoms like nausea, vomiting. Also look out for the other medications the patient is on. If it's the patient on a medication that could predispose them to, because if the patient has digoxin toxicity, then something must have caused it. There must be a reason. Okay, it could be due to the fact that the patient is on a medication that causes hypokalemia, like in this case, the patient being on furosemide. Okay. The goxin, how is it cleared? Is it cleared hepatically, or how is it cleared? Is it cleared via the kidneys or not? Or it's cleared renally, okay? So that's why your part one questions, that's why you always get those questions about the dose of digoxin depending on the creatinine clearance of the patient, because it's cleared renally. So the dose must be dependent on how well the kidney is functioning. Okay, so digoxin, is it used for rate control or rhythm control? Is it used for rate control or rhythm control? It's used for rate control, right? Yes, it's used for rate control alongside what other medications? Or what are the other medications for rate control? So B, C, D for rate control, beta blockers, calcium channel blockers, and digoxin. Okay, and by calcium channel blockers, it has to be the rate limiting calcium channel blockers like verapamil and diltiazem. So which of these medications on my screen can cause ototoxicity? A, B, C, D, or E? Which of them can cause ototoxicity? Furosemide, yes. Furosemide can cause ototoxicity. We discussed some other medications in the last session. Which one did we discuss that can also cause ototoxicity? Yes, thank you, Victor. Aminoglycosides like gentamicin. We said aminoglycosides can cause ototoxicity and they can also cause nephrotoxicity. So that's what remembering. So a patient started one of these medications and recently started having nightmares and sleep disturbances. Is it going to be A, B, C, D, or E? Nightmares and sleep disturbances. A. Okay, so that's one of the issues with bisoprolol. It can cause nightmares and sleep disturbances. Okay, and we said a certain class of beta blockers are less likely. Okay, is it the water soluble beta blockers that are less likely? Yes, thank you, Joy. Water cans. The water soluble beta blockers, cans is the mnemonic, C for celiprolol, A for atenolol, N for nadolol, and S for sotalol. Those are the medications that are less likely to cause nightmares and sleep disturbances. So a patient on one of these medications recently started experiencing swelling, okay, tongue swelling, face swelling, difficulty breathing. Which medication could be the cause? Tongue swelling, face swelling, difficulty breathing. Which medication could be the cause? Ramipril. Why? Why is it okay? So Presh said angioedema. We discussed this in the last two sessions or so. So ACEIs can cause angioedema. ARBs can also cause angioedema, but ACEIs are more likely to cause angioedema. Okay, so those are the symptoms of angioedema. A patient on one of these medications recently started having severe abdominal pain, nausea, vomiting, majorly the severe abdominal pain. Which of them could be the cause? A, B, C, D, or E? So I've gotten a couple of people saying sodium valproate. Okay, why? Severe abdominal pain. Pancreatitis. Thank you, Victor. Thank you, Joy. Okay. Acute pancreatitis presents with severe abdominal pain, and sodium valproate can cause acute pancreatitis. Which of these medications can cause weight gain? Which of these medications can cause weight gain? A, B, C, D, or E? Which of them can cause weight gain? Which of them can cause weight gain? Which one is more likely to cause weight gain? Does anyone know? Sodium valproate, actually, yeah, sodium valproate. Sodium valproate causes weight gain, And finally, which of these medications are used for symptomatic relief of breathlessness in patients with heart failure? Symptomatic relief of breathlessness in patients with heart failure, furosemide, okay? So furosemide is a loop diuretic. It's a loop diuretic. Loop diuretics are very effective and they are the treatment options for patients with heart failure to help relieve breathlessness and edema. So thiazide diuretics are not as effective as loop, okay? From what EGFR can thiazide diuretics be used? Generally, we only recommend that they are effective at a certain EGFR, medications like indapamide. So what EGFR is that? Yes, that's correct. From EGFR of 30. Okay, EGFR of 30 relief because they're only effective if if the creatinine clearance is 30 and above. Okay, on that note, we're going to end today's session here and we'll continue in our next session. Did you learn anything in this session? Have you learned something from today's session? All right, everyone. Thank you for joining and don't forget to share the group link to as many people that would benefit from the session. Thank you for joining. Have a good night's rest, everybody.